Good afternoon, everyone, and welcome to this meeting of the Health and Wellbeing Board. First of all, can I just tell you that there isn't likely to be a fire alarm test today, so if there's a very loud noise, please go out of the building to the front and stand in the car parks over that way, same way that you came in, or for most of you came in. And then other than that, everything is as it should be, I believe. Okay, so shall we move on to apologies for absence and replacement members, please, Rachel?
Thank you, Chairman. We have apologies from Councillor Mrs Bradwell, Councillor Mrs Rawlins, Councillor Marfleet, John Turner, Julia Debenham, Ruth Carver, Elaine Bayliss, Neil Juster, Malcolm Birch. We also have apologies from Heather Sandy, but we have Linda Dennett attending in her place, and apologies from Emma Tatlow, but we have Paul Gutherson attending in her place. Thank you.
And thank you for those replacements for coming, and especially welcome to Paul. It's good to see you. Moving on to declarations of members' interest. Do any of the members have anything to declare at all? No. Next, moving on to item 3, the minutes of the previous. These minutes were taken on the 1st of October 2024. Can we first of all just go through them for accuracy? Page 5, page 6, page 7, page 8, page 9, page 10. Sorry, Councillor Gray.
Madam Chair, that's fine, thank you. As I said to you, as the meeting started, Councillor Richard Wright's not with us today, representing the districts, and I do attend the district health and wellbeing meetings, so they asked me if I would just represent them with their comments. And one of the comments that they made with regard to the minutes was they were surprised that at the last meeting there was only 1 out of the 7 county councillors attending. And they thought that was very strange, that where were those people filling in on their behalf. So they just wanted to make that comment, that it was very strange that only 1 of the 7 were represented.
I think that's a fair point, Councillor Gray, and we will take it away with us. Thank you. Councillor Bowkett.
Yeah, could I just inform them that I was here, but I had to go to an emergency of a flooding. So I left, I was here and then I had to go again. So that's my apologies, but I was actually here, but I wasn't here, if you see what I mean.
Okay. And of course, the other thing I would say is, as you well know, because you are, as is Councillor Wright, you are both twin hatters, so you are county councillors as well, aren't you? Thank you. So we got to page 10, page 11, page 12, page 13, page 14, page 15. Are you happy that they are a true record? Can you just lift your hands if you agree? Anyone disagree? Anyone abstaining? Thank you. Moving on then to our next item, which is the action record of coming from those minutes. Agenda item 4, are there any actions there that we won't be discussing today that you wanted to bring to my attention, or indeed anyone else's attention? Okay, thank you. Chairman's announcements, I'll take, I say this announcement as read, and there's only one more to add, in that a thank you to the ICB. I was included in their regional workshop last week or the week before in Birmingham to discuss the proposals to put forward from the region for the NHS 10-year plan. It was a really vibrant event, and a lot of information coming through, and I particularly liked the way that they did the questions rather than just repeating questions on each table. If I can explain this, and I'm sure you'll do it much better, Jerry, but a comment was made, but then it was built on, and so then that same comment, if it grew legs, it went from table to table as we were moved, or it was moved round. So we all sat still, but the comments and the suggestions moved round the whole of the room. Very innovative, or at least I'd not been in that situation before, and I thought it was very useful because it was fresh information coming all the time, wasn't it, Jerry? Okay, thank you. So we move on to our first decision item, which is the pharmaceutical needs assessment. And I understand, Derek, you're presenting it, but then handing over to Tony? Or handing over to Tony straight away. Okay, Tony, floor's yours. Thank you.
Thank you, Councillor Waller. Thank you, everybody. Many of you will be familiar with the fact that the periodic production of a pharmaceutical needs assessment is a statutory duty on the Health and Wellbeing Board. Our next is due to be published next year, which will keep us tightly in line with the 3-year cycle for the delivery of updated pharmacy needs assessments. So the overarching process we follow is to bring a steering group of key people together, some of which are prescribed by regulation, some of which are just very useful to have in the room when we're considering need for pharmaceutical services into the future, to form a steering group. The steering group then leads the process of collection and analysis of quite a wide range of data to look at population need, look at the distribution physically of pharmacies and the distribution of services that pharmacies are providing to the local population. And the steering group's key responsibility really is to identify current or future gaps between the needs of the population and what is currently provided in pharmacies, including the geographical distribution and therefore the physical access to pharmacy services being a key component of that. So the span of responsibility around this P&A is to look at a 3-year or so period hence from next year onwards to make an assessment of current provision and future provision. And obviously the overarching purpose of that is to allow commissioners and potential providers of pharmacy services to look at any gaps and plan forward for doing something to address those gaps. Conversely, if no gaps are identified at the end of the process, then it gives assurance to commissioners and providers that there is no need to particularly look for development in pharmacy services over that next period of time. It is a bit of a snapshot in time, this report, inevitably so. We do, however, have processes in place under the auspices of this board to regularly review closures, reopenings, development proposals, etc., and consider whether they materially might change the view of the board about the adequacy of provision, and in which case we would bring something back to the board to give advice and ask for a further decision about those changes and what we need to do. So the scope of the P&A covers all pharmacy services provided by all pharmacy providers, pretty much. There's not a lot that's excluded from that, so that includes distance sellers, and you'll see in the P&A this time there is quite a significant growth in distance selling pharmacy provision at the moment all over the country, and Lincolnshire is experiencing that too. And one of the other highlights of that provision is the proportion to which general practices dispense medicines in Lincolnshire under rules around rural access to pharmaceutical services, where we have a lot of GP dispensing practices, but not unexpectedly so, given the nature of the population and the geographical distribution of the population and of services. So at this point, the steering group has done quite a lot of data gathering exercises. They've done some consultation and engagement with a range of stakeholders, including community pharmacies, with the public, under the auspices of Healthwatch. Thank you very much for your support in talking to the public about their experiences. We have pulled together basically a report which summarises gaps, future gaps, and adequacy of provision across a whole range of different services, broken into 2 main categories: essential services and other services. Those terms are described to some extent in the regulation, but we've grouped types of services together into two main groups for the analysis that we've undertaken for this P&A. So we've done that at a county level, including taking population growth and housing growth into account. We then have looked at an area by area analysis of data as well, and we've used district council boundaries for the analysis this time around, because lots of the routine data that we need to use is recorded at that population level, so it saves a great deal of additional work in repackaging data to do it in that way. And and at that point we have reached the production of a draft of the report. The basic findings of the report that's in front of you at the moment is that we have not identified any particular current or future gaps in access to pharmacy services for the population of Lincolnshire. Now, in coming to that conclusion, we've had to make come to some conclusions about what acceptable access looks like for local people, and in general we've used a geographical access definition of 20 minutes by car to a community pharmacy at various stages of the day, at various stages of the week, and on public holidays as well. And we've done an analysis of what proportion of the population in each district area would be able to access pharmacy services within that time period, or within that travelling time, I should say, and then drawn a conclusion about whether the proportion of the population that may not be able to achieve that is significant enough to warrant a development need or a gap in services. At this point in time, the report that the steering group recommends that there are no gaps in any of the service categories for any parts of the population that would be significant enough to identify additional need, either now or in the future. For the future figures, we have taken quite detailed data out of local plans for housing development and produced a calculation of how much additional housing we think might be built during the lifespan of the next P&A, given this is a 3-yearly activity, and we've tried to come to some kind of balance of whether that addition of new households would create a gap. We've largely focused in that area on developments where housing development is clustered together in developments of more than a certain size, because a lot of our local plan developments are quite small, quite dispersed, and are unlikely therefore to have much of an impact on demand for pharmaceutical services, whereas developments with 500 or more houses are much more likely potentially to create that kind of change in demand. Having looked at that in terms of future-proofing the P&A over the period in question, we've likewise come to the conclusion that the rate at which that housing is likely to be completed over the 3 years also, compared to the rate at which housing has been completed historically, is very unlikely to generate a level of additional need that would indicate that additional pharmacy provision would be required. Now clearly, if that rate of completion of housing changes in the run-up to the publication of this P&A or in its lifespan, we may well have to have a look at that again, but we obviously have to go on best analysis, best estimate of what is likely to happen. Because in some of those areas, it looks like there's an awful lot of housing going down in an area over a period of time. But when you then look at how much of that housing will be built per year over the lifespan of a P&A compared to the total number of existing households that are being serviced by pharmacy networks, that volume disperses quite rapidly and doesn't look like it would create a need for particularly additional pharmaceutical services in a given area. So fundamentally, you have the draft, the proposed draft P&A in front of you today. The steering group has drawn a range of conclusions from that, which fundamentally indicate that there's no gap currently or no gap forecast for the lifespan of the next pharmaceutical needs assessment. The next step now, assuming the board is content with the content of the report and the timeline to go out to publication, to consultation, is that we would move to public consultation on the 6th of January for 3 months. After that, obviously, we'll take on board the consultation and we will amend the pharmaceutical needs assessment accordingly. Thank you.
Thank you, Tony. Okay, are there any questions, first of all, as far as this draft is concerned? No. Can I just check with you? You said about you'd modelled on 20 minutes by car. From where? Is that from the venue of the prescription being raised, or where is it?
Okay, so the analysis is based on each site at which pharmaceutical services are provided and the extent to which every person in a particular area could get to one of those sites within 20 minutes by car. So it's the dispensing site, not the prescribing site, that the analysis is based on.
Okay, thank you. It's just I've got in the back of my mind that maybe with out-of-hours offers and etc., that particularly if you live on a border, then you can still be inside the county, and I'm thinking of the south of the county, but you then have to go into another county for to collect a prescription if it's out of hours or weekends or whatever.
It's certainly the case that pharmacy delivery outside of Lincolnshire has a significant effect on access for Lincolnshire people, but our analysis is primarily based on sites within Lincolnshire. But then when it looks like there may be a problem, we have then modelled whether there is access nearby, if not inside the county of Lincolnshire. So we've gone on the access basis rather than the place basis of where the pharmacy is located to check those things.
Okay, thank you. And before we sign the document off, I think I have mentioned it to Alison, but on page 24, right at the bottom, we're referring to CCGs. So if we could get that changed, please, that would be helpful. Thank you.
Absolutely. Terrible oversight. Sorry about that.
Off with his head, or whatever they do. Okay, colleagues, can we go to the actions required, which are to approve the draft PNA document ahead of the statutory consultation exercise, to note that the consultation on a draft PNA for Lincolnshire is planned between the 6th of January 2025 and the 8th of March 2025, and to receive an update on progress and the project plan timelines from the Lincolnshire PNA steering group on the production of the 2025 Lincolnshire PNA. Can you all raise your hands if you are in agreement? Anyone not in agreement? Anyone abstaining? Okay, thank you. Thank you, Tony. Okay, we move to our next item, and I understand that the presenter, Eve, is online. She wasn't going to be, but unfortunately she's got something nasty and she's decided she might be better keeping it at home or certainly somewhere else. So hopefully she's going to do her presentation, which will be item 7A, the Adult Mental Health and Dementia Programmes. Yes, is that spot on? Good. Okay,
Thank you very much.
Is she there?
I'm here. Can you hear me?
Yes, we can, Eve.
Lovely, thank you. And thank you for accommodating me. I just didn't want to share germs so close to Christmas or cough through everybody else's items. So I'm going to take the paper as read. I won't go through line by line, but I did want to summarise the content and highlight some key areas before opening up to any questions or comments. So the paper describes progress within the work streams that form the Adult Mental Health and Dementia Programmes within the Mental Health, Dementia, Learning Disability and Autism Alliance. And the Alliance is accountable to the Health and Wellbeing Board, which is why we're presenting the update today, and reports into the Better Lives Lincolnshire exec team. So the strategic priorities for the Alliance are around prevention and early intervention, maximising independence, improving quality and experience, reducing inequalities, and improving outcomes that matter to people. And what I hope the paper demonstrates is the wide range of developments across communities, prevention, primary care, secondary care, and where necessary, inpatient services for adults with mental health difficulties or individuals with dementia and those caring for them. The paper is an update of where we are currently at. More than happy to answer any questions or take any feedback. Thank you.
Okay, thank you. Are there any questions at all or comments? Thank you, Councillor Gray.
Thank you, Madam Chair. This is from districts. Councillor Nanstead had commented that he'd attended the Lincolnshire Suicide Prevention Conference and what a good conference it was. He made some good connections while he was there, so he wanted to pass his thanks to those involved with that. There was concern, though, that there was no mention of East Lindsey's range of memory cafes in the document. There are quite a number of memory cafes now with East Lindsey charities and districts are really working together on that. And it would be appreciated if these could be referenced because they are very well received and they are very well attended.
I will make sure that's updated. Thank you.
Councillor Bowkett.
Thank you. I've got two questions. The first is about the mental health in the community. I agree it's working well. We've got a lot of sites certainly opened up in East Lindsey where people can go to. But there is an increased rate of mental health, well, certainly within adult care. We've got a larger amount of people presenting themselves with mental health issues. And certainly since COVID, it has raised significantly. And I just do worry that people are out in the community more and we are having to pick that cost up, which, you know, somebody's got to pick it up. But I do worry since the wards have closed that people aren't in the correct place. I might be wrong. And then my second question is dementia. Dementia, if you're diagnosed with dementia and you're in the latter stages of dementia, where do you go for the care and support that you need? Because I don't see it anywhere. And they're my two questions. And she's disappeared.
Oh, I'm still
I said
here.
she's back. Sorry, I thought I'd scared you off for a moment.
Sorry, Dave, I'm still here. Thank you. Absolutely agree that we're seeing a greater prevalence, and one of the things that we're seeing as we extend out our offer into communities is that we're offering services to people that historically perhaps wouldn't have reached out and accessed services, which is brilliant. It means more people are accessing support for their mental health and well-being. But it just shows the scope of the level of need we've got. We are working really closely across the Alliance, so across health and with colleagues in the local authority and across other partner agencies to make sure that we understand what people's presenting needs are and how we can meet them in the least restrictive way and supporting people to live their best lives in the communities. So we are in a position in Lincolnshire where if someone needs a bed for their mental health, we will provide a bed. At times, for our in our acute pathway at the moment, that can mean that we have to fund a bed outside of Lincolnshire, but we will provide a bed for individuals where a inpatient admission for their mental health needs is necessary. I think you're right, there's some work for us to do alongside colleagues in social care to understand how we best support people who have a complex range of needs, who don't need to be in an inpatient service, but who do need support to live well in their communities. And that's a big part of the work that we're doing across our community rehab work streams, community mental health transformation, and the work that we're doing on our joint accommodation strategy, which is again across health and social care. So I hear your concerns. It is something we're aware of and looking at how we address it. In terms of the question around dementia and palliative care, it's a really interesting question, because as someone reaches end of life, if they require a inpatient bed because of the behaviours associated with the dementia, we have those beds in Lincolnshire. Our dementia ward is currently running at 75% occupancy. We haven't had to send anyone with dementia who needs an inpatient service out of county for the last 2.5 years. So we have those beds where the need is around their dementia. I think one of the challenges is, as someone with dementia reaches end of life, sometimes it can be the physical healthcare needs that actually are the most compromised. And I do understand that there's work happening across the county around what are we doing around palliative care, and are we getting that right? We will be feeding into that as part of the dementia strategy work that we're doing.
Yes, please do.
I'd look forward to hearing what's going to happen, actually, because I was obviously talking about personal experience, but a doctor who's just put my mother on palliative care and speaking to the community team, and to be told that what do I want, and asking for support and saying, well, it's not there. That's not your fault, Eve, but it's, you know, we do have a serious problem out there, and to keep people, I want to keep my mum at home, but I won't be able to without support, and the support isn't there. And that's not just your fault, that's both our faults. So we do have to do something about that. And that's not just with dementia, it's anybody who's dying, basically.
Absolutely. Could we pick up a conversation perhaps outside about the dementia home treatment team and what their role might be?
Yeah, I'd look forward to it. Thank you.
Yeah, thank you.
Councillor Burkett, do you have Eve's contact details, or do you want to get them through? You've got them. That's okay. Right, thank you. Any further questions from anyone for Eve? Okay, thank you. Thank you, Eve, and I do hope you get better soon. At least think of a positive. At least it'll all be over for Christmas, hopefully. So for the rest of us, if we can go to the actions required and just ask, we're asked to note the content of the report. Are you happy to note the content? Okay, thank you for that. Moving on to our next item, which is item 7B. This is the Lincolnshire System Winter Preparedness paper, and I understand we've got Rebecca and Natalie both presenting this, so I will hand it over to you. Thank you.
Thank you very much, Councillor Woolley. I'll start, and Natalie can obviously come in. So absolutely my pleasure to present the system winter plan for this year, and I stress system. This is about all partners working together into this plan. So whilst I sit here from the NHS and the Integrated Care Board, it is absolutely a collective plan that we work together. You'll notice it's quite a familiar presentation as well. I think we've presented it in this way over the past 2 or 3 years now, and that's because it's previously been very, very well received by our local population as well as our NHS England team. So the plan itself is built upon the pillar of prevention, and that's where I'll start really in the presentation. Prevention of our population becoming ill, and the best way that our population and all of us can look after ourselves, obviously, is through vaccination, and the vaccination of all those individuals who are eligible for not only COVID, which we talk quite a lot about, but predominantly influenza and also RSV this year. As always, in Lincolnshire, we're delivering our vaccination programmes through our network of community pharmacies, primary care, and of course our school teams who are visiting all of the schools. Many are now into their second visit of the year as mop-ups. The winter plan clearly articulates the risks for Lincolnshire. Those risks primarily are what we've seen in previous years, and that involves the risk of waiting. So waiting for a response, whether that's waiting in the community for a call back from your GP, 111, an ambulance, whatever you're waiting for, to then waiting for an ambulance to arrive, awaiting as people arrive into our emergency departments or urgent treatment centres, then if you were admitted, waiting for a bed, and so on through our pathway. But this year, there are 3 additional risks just to point out. Those being, firstly, we've got GP collective action currently underway across the county and nationally. And currently, there is nothing in the data suggesting that we're seeing any impact in relation to GP collective action. But of course, the winter is still quite young, and that may be something that might develop as the winter progresses. Secondly, the fragility of particularly our mental health services, but other services on the East Coast and Gloucester, and I know that's something you'll have heard about previously. And then the third one is about our population knowing how to access our services. I guess we all find it, I certainly do, quite easy working in the health service, but if you're not in the health service, it's incredibly difficult to know exactly what your need is and then to enter into the health service at the most appropriate point. So those are the 3 new risks, and within the plan you'll see some of the actions that we're taking to mitigate some of those risks. The plan's been developed with 3 core principles within it. Firstly, it's around attendance avoidance, so stopping individuals needing to go somewhere for something and actually providing that within or as close to the home as possible. If you do need to go somewhere for something, then preventing admission into any of our acute beds or anywhere else within the county. And then if you are an inpatient in an inpatient facility, then reducing your length of stay, so making that as seamless as possible. Clearly, the plan is based upon trying to understand what may happen during winter, and that can be quite tricky, even where we are in December now in the run-up to Christmas. It's very difficult to understand disease patterns, and as you build a plan, you want to put your greatest resource into the parts of the winter that is peak affected, and typically that tends to be just after January, when we often see some of the acute respiratory illnesses, some of the norovirus type illnesses really coming to fruition as people gather at Christmas and then go on their merry way as the children also go back to school. What we're seeing this year is a slightly different presentation, and you will be aware some of our services across health and social care have been incredibly pressured during October, eased a little bit in November, but again, coming back up into some pressure now. That kind of fits with our planning assumption, although it started a couple of weeks earlier than we anticipated, but this overall planning assumption of a cyclical approach to illness. So previously we might have talked about a peak and a reduction, but what we've seen certainly since COVID and what seems to be being experienced this year is that slight peak, and then we stay in that position, then it drops for a couple of weeks, and then we're back up. So it's much more cyclical, which gives that picture of a sustained pressure. That's what we've planned for in the plan. That appears to be what's happening, but as I said, it's still early. It's not quite Christmas yet. The sorts of things then that we've done, obviously the plan, I won't go through it in detail. I know many of you have heard me present this in other forums as well. Some of the things that we've done this year is we've looked at mainly how to maximise the resources that we've currently got. So one of the schemes that's had a really great impact is we've moved one of our senior clinicians from our clinical assessment service into the ambulance control room up at Gracebridge Heath, and they sit alongside the dispatch team. So when a 999 call comes in, all of those calls are reviewed by a senior clinician alongside the EMAS staff. And we're able to then dispatch a different range of service rather than just a 999 ambulance. So we're able to dispatch perhaps our community response services, our community nursing services, our home visiting services. We have a range of services that go out and visit those with a lower level of need in the community. And often people will dial 999 because they don't know how else to access support. So this is about getting the right response to the right individual within their own home. And we've seen a great maximisation of some of our community services and saved significant ambulance response times so far that we've been delivering the scheme. One of the other schemes that we're putting in place this year, you will be aware we have a mental health assessment unit in the Lincoln locality. So it's absolutely fantastic that in Lincolnshire, within that locality, we have minimal waits within our emergency department for those in mental health crisis, because they're took immediately over to the mental health assessment unit. We don't have that mirrored in the Boston locality, but what we're doing this winter is the development of a virtual mobile roaming team who will be based out at Skegness, covering the coast and into Boston and into the rural parts of East Lindsey and Boston area. In a mental health response, there's a slightly different methodology to a MUAC. Clearly, it's not possible to just build a mental health assessment unit in Boston for the winter. So that's just something different that we're trialling. Obviously, the plan details a range of other initiatives that colleagues in adult social care are delivering around increasing what we call Pathway 1 capacity. So that's individuals coming out of hospital needing packages of care. So we're able to respond to people and really address some of the risks that we've articulated within the plan. Clearly, we're already seeing nationally this is going to be a difficult winter. And I'm sure as we get further into winter, some of those challenges will come to fruition for Lincolnshire. But at the moment, we have a plan that is holding currently for the people of Lincolnshire. There are lessons to be learned throughout. It's an agile plan, and I probably should have said that at the beginning. Although it's gone through our governance, it's not a standstill document. So we're forever learning, and the reason I'm leaving after here is we're going straight to a meeting where we're looking at what happened over the last 2 weeks, what can we learn, what more can we do to bolt onto this plan. So it absolutely is agile. Natalie, is there anything else you would like to add? I could talk forever.
Thanks, Rebecca. So just picking up, I suppose, that point in terms of being an agile plan and some of the presentation of what we've got at the moment. I suppose one of the strengths that we have as a system in Lincolnshire is our ability to pivot in terms of what the data and intelligence tells us. And that's what I would just echo in terms of this plan. So the mechanisms around surveillance, particularly in terms of that disease trajectory, but also in terms of the threat and the implications for workforce. I think we recognise the previous winters and just how difficult they have been in terms of workforce. So actually this year's plan is very centred around our healthcare workforce, our social care workforce, and making sure that in partnership actually that we're able to support those staff to access, particularly in terms of the vaccination programmes, recognising that previously there have been barriers to accessing. This is the first year where actually we've trailed offering additional clinics through county council, through to our social care colleagues, and really uniting in making sure that we are a resilient, cohesive workforce as we head in. But that is certainly something that we'll be taking forward and happy to give the learning in terms of that going forward.
Thank you, Natalie. Questions, anyone? Melanie.
Thank you, Councillor Woolley. I just wondered if you are going to think about putting in the additional risk of the potential reduction in adult social care provision between now and April, as people start to cut down their staffing in response to the budget. I think that will probably start to play out in January, February.
Thanks, Melanie. As I said, this is an agile document, and clearly what hasn't been articulated so far is financial risk, but there is absolutely a financial risk across health and social care. And I have to acknowledge this is the first year that we've not received additional money for the winter plan. That said, we knew we wouldn't, so we planned for that. And we were able to build in these schemes through planning. So that's one of the richness of Lincolnshire, in that we'll come together and we'll absolutely plan in response. But I will take that away as part of our ongoing review. You won't be surprised that the conversation tonight will feature finances will feature very heavily on that, because it will be what can we do, what can we afford to do, and what's right to do for the maximum impact for the people of Lincolnshire.
Thank you, Rebecca. Martin, and then Jerry, and then William.
Thank you. I really ought to pick up the comment that Melanie has made. I think that we are all very conscious that in our process of looking at fee rates for the coming year, we are always aware that there is a pressure from inflation, there's a pressure from the national living wage going up, and of course the national living wage goes up much faster than inflation does, and rightly so, because the staff deserve to be paid properly for their work. We have this year been thrown the unexpected position of the change in employers' national insurance contributions. We are awaiting with anticipation the local government funding settlement, which is due in I think next week. 9 days time, right? 9 days time. Well, we'll all be opening that file with considerable interest. I think it's fair to say that members of this council have been making very clear to the government their concern about the potential impact on the social care system from those national insurance changes. It's quite interesting that the government chose to protect the NHS from that change, but to date has not decided to protect adult social care, despite the fact there are more people who work in adult social care than there are who work in the NHS, and that in fact in many respects the changes are more impactful on social care than they are on the NHS, because of the changes in it's not so much the change in the rate, the percentage rate that's charged, it's the change in the thresholds. I mean, Melanie will know the details better than I do, but it does actually have a much bigger impact on social care than it does in the NHS, but the government has chosen to protect the NHS and not adult social care. I say members of this council have been very clear and very public about their support and concern about this issue. Through my professional association, the Association of Directors of Adult Social Services, we have been being very clear with government about the consequences and the impact of these changes, and the fact that, as Melanie rightly says, it's not something that will only start to happen when the changes actually kick in at the beginning of April. The providers have a need to prepare for these things. Obviously, the County Council is in the midst of its budget setting process, and we will be using that to inform our contract negotiations with providers. So clearly, I'm not in a position to give any definitive answers or statements at the moment, but I think we are very conscious of the issues, and we will be seeking to have full regard for those in the process that we'll be going through. Worth saying that the relationship, the very positive relationship we have between the County Council and Lincolnshire as the representative body for providers, I think will stand us in very good stead for finding the best solution that is available within the situation.
Jerry.
Thank you very much, Chair. Just a few observations. Firstly, to build on the comments that have already been made, the ICB at its last meeting in public also received representations from our voluntary and social care sector partners, a representative, and after a discussion similar to what Martin has just referred to, we added this particular matter to our risk register in terms of an emergent risk, and we recognise the significant potential that this will have to be quite disruptive as we move forward. Secondly, Secretary of State and NHS leaders had a webinar yesterday morning that many NHS leaders were able to attend. I think I'll just highlight a couple of points from that, if I might. Firstly, Secretary of State wanted to emphasise to health services that they needed to prioritise patients with the greatest need, or those that face the significant harm, significant harm, and not to chase targets by just trying to get low-hanging fruit through the ED departments. I have to say, personally, I think that's not something the NHS needs to be told, but nevertheless, Secretary of State did feel that he had enough evidence to suggest we needed to be reminded of that. And lastly, it's incumbent on all of us to make sure we got the maximum numbers of our staff vaccinated as we go, even into this latter stage of the winter, and some of vaccination rates could and should be higher than they are, and that's across the whole spectrum of health and care in the county. So thank you very much, Chair.
Thank you, Jerry. Councillor Gray.
Thank you, Madam Chair. Thank you, Rebecca and Natalie. You mentioned, when you were giving your presentation, indeed it says in the report, there is an identified risk around the level of capacity in our mental health services across the East Coast of the winter period, so the ICB will increase capacity. I'm just wondering, is it actually increased capacity? Is that an extra resource, or will you just be juggling the resources from elsewhere? Because if that's the second scenario is the case, that really is worrying. And then over the winter period, with regard to discharge from hospital, it would really help if there was some coordination and standardisation with that, because it would really help with coordinating the care in the home, because so often that doesn't seem to be the case. Suddenly someone's discharged and that's it, with very little thought into what's going to happen when they get home. So if that hospital discharge could be really standardised, it would help greatly, especially during the winter.
Thank you, Councillor Gray. So I can confirm that the first question, that is additional resource onto the East Coast. So as I said, we had very little money, but that money we've invested in the highest area of need. So that is additional staff and an additional team out in that area. With regards to discharge, there's a lot of work going in to discharge, but if I can take your comments away, because I know individuals will have various comments, various experiences, various observations, and we will continue that work around seamless discharge. Thank you.
Any further questions from anyone? Okay, if we now move to the actions required, and we're asked to consider the work undertaken in preparation of Lincolnshire's winter plan and to advise any other areas for consideration or inclusion as part of the enhanced offer. So I don't see any suggestions or whatever. So can we move to a vote? All those in agreement, please raise your hands. Anyone against? Any abstentions? Thank you. And thank you also, Rebecca and Natalie. And by all means, if you need to dash off now, please do so. Okay, we now move to item 7C, which is working age adults presentation. And this, I believe, is a presentation by you, Martin. So I'll leave it with you. Thank you.
Thank you. Yes, it is indeed me. I'm not sure whether Rachel is going to be able to get the slides on the. I'll start talking and buy you a little time. So one of the things, it's very easy and quite common for people to think of adult social care as being a service which is primarily focused on older people. And one of the issues that we often highlight is that in media stories about adult social care, the norm is you'll see a photo of someone in a wheelchair, an older person in a wheelchair, or a pair of wrinkly hands, or sort of someone with white hair. And clearly, adult social care does do a great deal of work with older people, but actually we now do more work with working age adults between the ages of 18 and 64 than we do with older people. So as it says on the slide now, it's so a few years ago nationally we reached the position where it was about 50-50 in terms of expenditure, where about 2/3 of the people that we supported in adult social care were older people, and about 1/3 of the people were working age adults, but the budgets were about the same. On average, an adult, a working age adult with care needs is about twice as expensive as an older person, a person over the age of 65. That process has continued to shift, so that in fact there was a national report published about a week ago which said that in many parts of the country we're now reaching a 2/3 of expenditure is on working age adults and 1/3 on older people. Now in Lincolnshire, because of our different population, we're still some distance off that, but we are moving towards it fairly rapidly. So what we've seen is a really significant increase in costs for working age adults over the last 5 years or so, and indeed, it's increased by about 1/3 over the last over that period. And there is some increase in the overall number of people, particularly in the area of mental illness, and we've touched on mental illness a couple of times already this afternoon, and I'll come back to it again in a few minutes. But what we're largely seeing is the level of need that people have is growing quite rapidly, and in particular, what we've seen is that the people with the greatest need have been seeing the greatest rate of increase, and that's been causing particular stress to the system. And so if we extrapolate this forward, as the slide suggests, that by the end of the decade we could be spending £17 billion a year on working age adults. To put that in context, the total national spend on adult social care is about 22 billion at the moment. So you can see how we will the balance and the total amount will grow very considerably. I suppose it is worth putting this in context that as I think the annual budget for adult social care nationally, I say, is about 22 billion. I think that's about the same as this year's growth in the NHS budget. So the NHS budget is, I think, 6 or 7 times the adult social care budget. It was not that differential has grown very much over the last 10 years or so. It wasn't that long ago that they were not that different in size. The NHS budget has grown rapidly, the adult social care budget has not. That national picture position very much being expressed in Lincolnshire as well, and I'll come to that in the next couple of slides. So if we move on to the next slide. So the charts there, hopefully they are easy enough to see. So the light blue line in both cases is the England average. The dark blue line is the statistical neighbours for Lincolnshire, and then the green line is Lincolnshire. And what you'll see is if you look at the number of people with mental health issues in the adult social care system, then we are and remain well below the national average, and indeed below our peers. And interestingly, over the last couple of years, our statistical neighbours have caught up with the England average, but we are rising quite rapidly. And I think the key thing is that issue about the increase in the number of people with mental health illness who are in the adult social care system growing quite rapidly. By contrast, if you look at the right chart about learning disability, although we are identifying within the population many more people with learning disability, the number of people who are in the adult social care system per 100,000 of the population is staying pretty similar, and indeed in Lincolnshire it's fallen slightly. National data isn't readily available in some respects about differentiating by diagnosis, but it's interesting that Lincolnshire has overall a distinctly smaller proportion of the working age adult population in the social care system than you would expect us to, given our statistical neighbours. But you can see that learning disability pretty stable, mental health rising rapidly. So if we go to the next slide, then these are provisional figures that we're working on in terms of the budget. What I would particularly draw your attention to is the contrast between the mental health rows and the learning disability rows. So we are essentially seeing that the increase in the national living wage and inflation is the bulk of the pressure in terms of working age adults with learning disability, but it is only a small proportion of the pressure in terms of mental health issues, and that what we're seeing is a much larger demand pressure for mental health than we are for learning disability, and there are a range of factors driving that. But the key thing we're finding is that there are more people coming into the mental health, the adult social care system with mental health issues, that they are more complex, and there's a clear connection between those people who are entering the adult social care system under what's known as Section 117. This is essentially that someone who has been detained under the Mental Health Act, when they are then discharged, that their ongoing care needs are provided are not chargeable. Now, of course, for the NHS that makes no difference because NHS care is free at the point of delivery. We always need to remember that adult social care is a means-tested service. The Mental Health Act, Section 117, says that if you have aftercare having been detained under the Mental Health Act, then the social care you receive is also free at the point of delivery, and therefore the council has to pay for that. And that is becoming a very, very significant cost pressure for us. We're also seeing now the impact of the massive increase in children and young people with education, health and care plans. They are now aging out, and they are becoming young people with generally mental health issues, which are drawing them into the adult social care system. So we're seeing a very significant increase in the number of young adults who have been through the children's system. And I think it's generally acknowledged that although spending on the SEND system in the children's world has increased very, very rapidly and very significantly, the outcomes in terms of the level of well-being for these people when they become adults have not improved. So we are spending a very great deal of money leading to people who are still quite dependent in their need when they become adults. So significant pressures for us there. So we've moved to the next slide. You'll be relieved that I'm not intending to go through this in detail because even my eyesight is quite challenged with this. But essentially, what this shows is that we are seeing pressures in terms of people who are in residential placements, whether for learning disability or mental health. But our real pressures are for the people who are well enough to be in the community with support. And there we are seeing a rapid increase in the number of individuals and the cost of their care. And this is in fact now the second largest individual cost pressure for the council. Now I should just qualify that slightly, because referring to the conversation we had previously, we haven't built in the national insurance changes, the employers' national insurance changes into any of these figures. We're still working that through. So that's a significant additional figure. But it is the demand growth for working age mental health after the home to school transport it's the next biggest pressure within the whole of the council. So if I say a little bit then on the next slide about how services for working age adults, adult social care services for working age adults are delivered, we essentially have three different arrangements. For working age adults with a learning disability, we have a Section 75 agreement with the Integrated Care Board, and that means that the County Council is the host for the arrangements, and effectively we coordinate and manage learning disability services for everyone, whether they have primarily a social care need or a continuing health need. For mental health, it's the other way around in effect. So the County Council has a Section 75 agreement with LPFT, so that LPFT delivers an integrated service on behalf of both organisations. And then for physical disability, for working age adults, we don't have an integrated system. So we provide adult social care through one of my services, and obviously the NHS provide their services. Worth noting that a fairly significant proportion of the working age physical disability services are for people with acquired brain injury rather than people who have a lifelong disability. So it's, essentially people have had car accidents, and that's an important part of that area of business. So if you move on then to the next slide, as part of the improvement work that all of the 10 local authorities across the region do together in terms of adult social care, we have a programme, a long-standing programme of peer reviews, whereby teams from across the region will come into a local authority for a couple of days to look in detail at a particular area. So about 3 weeks ago, we had a team led by John Wilson, who is the DAS in Leicestershire, and he came with a team, and they looked at the issue of transitions in Leicestershire, just to evidence in Lincolnshire, sorry, just to evidence that it is a reciprocal process. Last week I was in Derbyshire leading a team that was a regional team that was doing an equivalent review for Derbyshire County Council, looking at their services. They had a slightly different focus to theirs. So I've set out there in the slide a very brief summary of the findings of that review. There's a number of areas where the review team felt that we were doing really quite well. They highlighted the good collaboration between adult services and children's services. They highlighted the very positive work being done by our new physical disabilities transitions team. They underlined that it was very clear that we had a strength-based approach and that there was scope within the service for innovation and for service development. They identified a number of areas where they felt that it would be useful for us to do things slightly differently, or to focus our improvement resource. And so I won't go through those individually, but they're up on the slide. We are taking those and building them into the overall transformation programme that we are developing for adult social care, which is bringing in the recommendations that came from the Care Quality Commission inspection that was about a year ago. We've also had a peer challenge process through the regional ADAS process, and a range of other things that we have identified. So we are building this all into a single plan, and we're working very closely with children's services on that. So if you move to the next slide, then there are a range of things that we are doing to try to address the challenges that we're seeing in terms of working age adults. I think a couple of them have been touched on already this afternoon. I think I'd just reflect a couple of these. So one is the fourth bullet down, we talk about accommodation. One of the things that has become apparent is that Lincolnshire has a much smaller amount per head of population of supported accommodation in the community than you might expect us to if you compared us to other similar authorities. So we're doing some work to understand how much might you expect to have, and the national rule of thumb is that you should have between 10 and 15 units of supported accommodation for every 1,000 people between the ages of 18 and 64. But that's a national assumption. So we're doing some work to see, well, Lincolnshire is a unique place. We're all very conscious of the unique geography and population distribution of Lincolnshire. So rather than just saying, well, we ought to have 10 to 15 per 1,000, we're doing some work to look at, in the Lincolnshire context, how much should we have, and where should it be, and what sort should it be. But I think the initial indications are that we will probably need significantly more than we have at the moment, and that might connect with although Lincolnshire has a lower proportion of the working age adult population in the social care system than you might expect us to, we have a higher proportion of that population in residential care than you might expect us to. And that may suggest that we have less supported accommodation in the community than would be appropriate for our population, but we need to do some work there. And then the other one I'd reference would be the Better Lives initiative. So this is some work we've done with a consultancy called Empower. Members of the board may be aware that for some years now, Lincolnshire County Council has been working with Empower for, using a tool called Valuing Care, which is designed to help a deeper understanding of the needs of children who are looked after. We are the first place in the country to try to take that tool and say, does it work for adults with a lifelong disability? We've now taken about 400 people through that process, primarily in the working age adults with learning disability area, which is where we started. And we've found it is giving us really good insights into people's needs and allowing us to look at the cohorts and within the working age adults with learning disability population, and to understand the need and the nature of the need and the change over time. It's also been helping practitioners to understand the individual people that they are working with in more detail. I mean, of course, practitioners have a very deep understanding of individuals already, but it's giving them an even deeper understanding, and it's also allowing us to understand the cohorts and to work out how we can address their needs collectively better over the coming years. So a lot going on. So really, just to conclude, if we go on to the last slide, as I say, nationally we are seeing, as a sector, a significant and rapid increase both in numbers and complexity for people working age adults needing social care, particularly in the mental health area. I say less so in learning disability, but particularly with mental health, and Lincolnshire is no different from that. The rate and level of growth is not something that we can sustain in the way that it is at the moment, so we are developing a joint plan to make sure that we can address the needs so that Lincolnshire people are able to have the best possible life outcomes, able to lead the best lives that they possibly can, and therefore to have the maximum independence in the community, and therefore they're likely to have the lowest need for formal care services. We're absolutely clear we need to work with partners in order to deliver this. This isn't simply a local authority issue. One of the things that's becoming very clear nationally is that, in fact, the organisation that probably spends the most on working age adults in the social care system is, in fact, the DWP through the benefits system. And so there is quite a lot of work going on nationally to explore the potential for bringing DWP more into these conversations, because in fact it's one of those things that's a bit behind the scenes, but actually they're probably spending more on this than health and social care put together. We're very clear of the need to work very closely with our colleagues in children's services so that young people have the best possible route into adulthood that leads them to be as well prepared for adulthood as they possibly can be, and not experiencing then a cliff edge where at the point where the legislation for children's ends and the legislation for adults starts, and the expectations and experience are rather different. We need to have a clear focus on outcomes for individuals, and of course there is therefore a huge dependence on the effectiveness of secondary mental health services, and Councillor Bowcoat was referring to those earlier, and particularly of the community mental health services, because that's, clearly if people are able to maintain a good quality of mental health, then they won't come into the mental health part of the adult social care system. But that's a relatively brief summary.
Thank you, Martin, and very interesting and informative as well. That's much appreciated. Are there any questions or comments that are arising from that? I have one. Just going back a little bit under those what's working well, the peer assessment, the opportunities for improvement. One of the bullet points is data and intelligence, improve data and intelligence capabilities to inform strategic planning and commissioning. Is that a polite way of saying that all of us as a system should have the ability to share that data more, or is that just very specific to us? Who does that include?
I think it's going to be a both and. So I think that it's become clear that the maturity of the county council in interrogating the data that it holds needs to develop, and Derek beside me is nodding on the basis that we are drawing in our colleagues in the public health intelligence team who have significant expertise in the understanding of data. So we need to move forward as a county council in terms of our use and understanding of the data, and then we need to get that bigger picture of understanding the experience of people's lives in a totality. I mean, one of the issues that we found just within the county council has been that that our systems tend to record people by the service which they access, but the same individual may be accessing 2 or 3 or 4 different services, and so it's quite difficult for us, or it has been quite difficult for us to say, well, what is the total number of individuals that are in the system, and what services are they receiving and what do those cost, rather than saying, well, we've got this number of people who are accessing day centres and that number of people who are having community supported living and that number of people who are having a direct payment. In some cases they are the same people, and in order to make a proper assessment of the best way forward for that individual, we need to understand them as an individual, not as a series of services. And I think as we develop that picture, that expertise, to being able to do that across the health and social care system as a whole, because although, again, in the NHS there tends to be a focus on older people who are stuck in hospital for a variety of reasons, I think my understanding is that often people with a learning disability, working age adults with a learning disability, it's much more likely for them to find it, when something happens, they go into hospital, and then it can be very difficult for them to move out smoothly back into the community. So it's a significant issue, I think, for all of us.
Thank you. And have a well-deserved, well, I was going to say have a well-deserved rest, but you can't, can you? Because we will move on to our next paper, which is the Better Care Fund update, or are you going to hand straight over to Paul?
Well, I'll just say a couple of words and then let Paul in. So there's standard approaches with the Better Care Fund, and this is one of our usual updates. I thought I'd just say a couple of words about where we are looking forward. At present, our plan is a 2-year plan which runs until the end of March of this coming year, March 2025. There has as yet been no formal statement in terms of what's going to happen next year. The smoke signals that are being given are that probably there'll be a 1-year roll forward or extension of the current arrangements, and then as part of the National Comprehensive Spending Review, that there will be a new position taken on should there be a Better Care Fund at all, and if there should, then what nature should it take? So we're waiting that, but our expectation is that the current arrangements are likely to be taken forward for another year broadly as is, but that we have been doing some work locally within Lincolnshire to review the schemes and programmes that we have within the Better Care Fund to make sure that we really have got the boundaries of it set in the right place, and that the schemes that we've got in there are actually having the impact that they ought to have within the sort of shifting nature of the national guidance. But that was all I wanted to say by way of introduction, and then Paul is much more expert on the detail of the actual report than I am.
Thank you, Paul.
Thank you very much. So I'm just going to run through firstly the quarter 2 report and just a couple of highlights. So as you know, we're required to submit these quarterly. This one was submitted on the 31st of October. However, it requires retrospective approval as we know, as we've been through before. This last report looked at the performance for the last quarter, covered metrics, finance, and any changes that we were making kind of around winter planning and demand capacity. So the updates for that are there's currently no changes to the plan that we submitted previously. Our kind of 4 metrics across the system are working well, and we're on track to meet those, which obviously was quarter 2's. The winter system plan and readiness is completed and as part of this, and then you'll probably note that on our demand and capacity there were some blank figures, and that's mainly down to some system-wide data issues that we're working together. So we spoke to our kind of colleagues at the national team as well as our regional team to go through our data processes, and we're currently working across that kind of one version of the truth. And we have reassured them that we are ready to go kind of for quarter 3, which will be into February. Martin's covered the kind of national perspective on the future directions of the Better Care Fund and where we're going on that. So at the last meeting we had an update on the Better Care Fund review. So we've kind of focused on 2 areas, learning disability placements and intermediate care. So I've included in the report there were kind of 11 key recommendations around LD. I won't obviously go through each one of those. And a bit of an update around that and the work that's being done is the recommendations there were discussed at the Learning Disability Joint Delivery Board, and it's been agreed that they'll remain a regular agenda item so they can continue to monitor progress until each area is completed. So they've also agreed to share the recommendations with the LDA Delivery Group as they're more system working level recommendations. These recommendations will then sit as standing items on that agenda going forward. However, it was to note that the work will take time to implement. For example, the Empower work is subject to a significant programme of due diligence and is unlikely to be concluded quickly due to the complexity there. At the last meeting, we had around intermediate care. We didn't have the recommendations at that point. They were just ready to be signed off. They have been completed and fed into the Joint Commissioning Oversight Group. There are 9 key recommendations from this, and again, I won't go through them. However, there are some key areas that are coming from that which is fed into the work that's being done now. So these recommendations were accepted by JCOG, and so the work that's currently being carried out includes developing of a strategic group alongside some operational groups, which is now in place to complete and design a Lincolnshire integrated care strategy. Both the ICB and LCC are working together to write that strategy, and this is being developed from the information that's been taken from those working groups. The aim then is for the strategy to be ready for late December or early January for executive oversight, and that's also then being aligned with winter planning for 25, 26 and 27. And just a point on that is that active recovery beds and reablement will continue throughout the winter, and these recommendations will fit into this strategy as it carries on. So those 2 areas and pieces of work will now be taken on by the operational teams within the ICB and LCC to kind of progress that work. And as Martin has said, we're now focusing on other areas of the Better Care Fund to look at the schemes and develop more the work around that.
Thank you, Paul. Any questions or comments from anyone whatsoever? No? Okay, thank you very much. Can I just move to the action that's required then, which was to review the BCF for 24-25 quarter 2 report, which we have done, and then note the update on the BCF review. Can we all agree that we've noted that? Thank you. Any against? Any abstentions? Nope, fine. Thank you. We now move on to item 8A, which is a log of the previous decisions. Anybody have any comments they wish to make on any of the previous decisions? No. And then the forward plan, item 8B. As always, if there are any items you feel should be on our next meeting agenda and aren't, please let one of us know. If not, then it will look something like the paper as read, but allowing for a little bit of leeway, because of course we will have a better idea then of what monies are involved, probably from the budget, etc. Okay, so on that note, I will thank you all for attending and close the meeting. Thank you.